We will discuss criteria of screening test. We'll discuss this session according to following learning objectives. First, what is disease criteria? What is test criteria? What are various examples? And what in the end we will summarize the session. There must be some criteria to conduct a screening test. As a screening test is done for a disease with the help of some tests. So the criteria is criteria for disease and criteria for test. And these test is done in healthy individuals or apparently healthy individuals in a specific population. So for a successful screening test, we will select a criteria for disease. The disease must fulfill that criteria. We set a criteria. We say, or we can say that we can set a inclusion criteria. Which disease should be included? And criteria for test. Which test should be included? Certain tests they are not reliable. We will not include these tests. So let's discuss this criteria one by one. What is the criteria of disease? Number one, disease must be a public health problem. What is meant by public health problem? It is affecting communities or it is affecting greater number of people. Like coronavirus is a common public health problem in Pakistan nowadays, or it's a common public health problem in the whole world. So disease must be a public health problem. For second, natural history of disease should be known. We should know the natural history. We should know the steps of disease process. What are steps of disease process? Like what is pre-pathogenesis phase? What is pathogenesis phase? What is the outcome of that disease process? Plus, disease must have a longer latent period. So we select the disease according to this criteria. It's a burden, it's a problem. Natural history is known, latent period is greater than. We must have diagnostic test. Or we can say that diagnostic test should be available. Why? Because if we screen a problem and we don't have any diagnostic test, we are wasting time, we are wasting money, it is useless. So we must have certain diagnostic test. Then after screening, we will diagnose, then there must be some treatment. There should be some treatment. Plus, benefit should be greater. We must have certain benefit from this screening program. We must remember this criteria. The screening is done usually for chronic diseases, or it can also be done for communicable disease in case of coronavirus. These criteria may differ, but we have to remember these 6 criteria. That the disease must be a common public health problem, disease is spreading, majority of population or communities are suffering from the disease. Many people are suffering from the disease has a greater burden, it has a greater incidence, it has a greater prevalence, it has a greater attack rate, it has a greater mortality. Plus, we must know the natural history, we must know the various steps, we must know the unfolding of disease process, and it must have a greater latent period. Like it must have latent period of days, months, like in case of tuberculosis. In case of cancers, they have greater latent period. And it must have some diagnostic test. It must have some treatment and benefit should be greater. If we apply this on hypertension, we know that burden of hypertension is greater. People are getting the disease day by day. Its incidence is increasing. So it's a common public health problem. It's a problem of middle age and old age people. We know the natural history of hypertension, how it develops, what are risk factors of hypertension, what is outcome of hypertension. Then we know that latent period is greater. Then we know the diagnostic test of hypertension. We know how to trace blood pressure. Then treatment of hypertension is available. We can give certain medications. We can give AC inhibitors. We can give beta blockers. We can give calcium channel blockers. We can give diuretics to treat hypertension, combination treatment or single treatment. Then benefit is greater. We are protecting our population from the disease. But sometimes our disease doesn't fulfill the whole criteria, like in case of coronavirus. We all know that coronavirus is a common public health problem, but we don't know the natural history of disease completely, or we can say that complete natural history of coronavirus is not known. Latent period is known. We know the diagnostic test. We know that we can diagnose coronavirus from PCR, from high resolution CT scan. But there is no specific treatment of coronavirus. There is only symptomatic treatment, but benefit is greater. Why we screen coronavirus then? Cause we want to protect our population. It spreads from person to person. We'll isolate the case of coronavirus, then we are protecting other people. And we are doing this for prevention purposes, the main purpose of screening. So it is not necessary that a disease fulfills the 100% criteria. So we have to see the burden. We have to see whether this is a common public health problem or not, and see the diagnosis. And we have to see the benefits. If the benefits are greater, if it is influencing larger population, it is affecting larger population, we will go for screening. What will be criteria of a test? We know that screening is done by rapidly applied tests. Our screening tests are rapid. They are done in masses. They are cost effective. So there can be some errors. So we have to follow a certain criteria for screening test. Which screening test will be selected? Those who are reliable. Answer should be accurate, valid, or we can say accurate, simple and inexpensive. Screening tests should be simple, like we are checking diabetes or checking sugar in a population. We are simply doing blood sugar. It is inexpensive test. It should be safe. It should not do a harm to a community, harm to a population, or harm to a person. It should be acceptable. Those screening tests which are not acceptable, we can't apply them to the community, because we need community participation. If the community is not accepting a test, he that community will not participate, and that screening test will not be effective at all. Cost effective, yes. Exit strategy. What is meant by exit strategy? We must have a plan. We are doing a screening program. When we will apply it and when we will stop it, when we will conclude it. Definitely, in case of coronavirus, nowadays we are screening coronavirus, but when disease will end, we must have exit strategy. We'll stop screening coronavirus. Or in case of polio, if polio is eliminated, we will not screen. Or smallpox is not screened nowadays, plague is not screened nowadays. We adopted an exit strategy that they are eliminated, they are eradicated. Now there is no need to screen them. What is reliability? Definition reliability. Reliable means trustworthy. Screening test. If it is repeated again and again, answer should be same. That is a reliable test. Like if a screening test is done to see the hemoglobin level, we repeat it 100 times, answer should be 10 in same person, not in different persons. What are the causes of unreliability? There may be certain errors, there may be certain variations, like observer variations, mechanical variations, and biological variations. Observer is doing a test, he is not trained, he can make mistakes. Machines, they are not maintained. Biological errors, we know. Our blood pressure changes with time to time. Blood sugar changes with time to time. Blood pressure is not same at night time and at morning time. Blood sugar, that's why we see fasting blood sugar and random blood sugar. Before eating the food, blood sugar is not same. It's different. After eating the food or after taking the food or some fast food or some sweets, blood sugar is different. These are the biological errors. Like we can say that observer variation, mechanical variation, and biological variations. Observer, there are two types: intra-observer, inter-observer. Same observer is making mistakes again and again. This is intra-observer. Different observer have different results. Inter-observer, mechanical. There is error in machine. Biological, like continuous variables, like blood pressure, blood sugar. They are different at different times. Like someone is checking the sugar at fasting time, sugar is low, and if he checks the sugar after taking food, sugar is different. This can be the error. This there can be problem in interpretation. So we must know the condition. We must know that continuous variables change from time to time. Acceptability. Which test will be acceptable to the community? That is not painful. That should not be painful. That should be safe. That should not be discomforting and embarrassing. Socially accepted, like you are doing pap smear for screening of cervical cancer. We know that cervical cancer is present in female of low socioeconomic status. If test is performed by male, this test is not accepted. Our community will not accept this test. So we have to target our community. We have to train female to do these tests, and the test will be acceptable to the community. That's why you apply or for vaccination of pregnant ladies. Our society will only accept females. They are trained. So we have to follow this criteria. Validity. A test has results. Either person is diseased or non-diseased. But a screening test can generate false negative and false positive results because it is rapid. So it is the ability to distinguish between those who are diseased and those who are non-diseased, or those who don't have the disease. We have to see the validity. For validity, we see sensitivity. Sensitivity means that those who are diseased, percentage of those who are diseased, specificity, those who are non-diseased. Ideal screening test must ideal screening test should be 100% sensitive and 100% specific. It must yield 100% disease and 100% non-disease accurately. What is yield? Diagnostic power. Predictive value. There are two types of predictive value: positive predictive value and negative predictive value. Positive predictive value means that those who are positive, those whose screening test is positive, it must contain true positive. For an ideal screening test, all should be true positive. Negative predictive value, those who are negative, ideal screening test should have 100% true negative individuals. It may not be possible because it is applied on masses. How to draw 2 by 2 table? Those who are diseased, those who are non-diseased, then test positive and test negative. You can draw it in this way. These are diseased. Here we see the disease criteria, and there are two individuals, those who are diseased and those who are non-diseased, and test can be positive and negative. A, B, C, D. This is 2 by 2 table of screening test. And now we will see sensitivity of a screening test. What is meant by sensitivity of a screening test? Sensitivity means ability of screening test to identify those who have the disease, or we want to see the percentage of those who are true positive among disease. So screening test can yield positive and negative results. Positive are true positive and false positive. Negative, there may be false negative and true negative. What is meant by true positive? True positive means that those who are the disease and those who are diagnosed as diseased. False negative means that these people are diseased, but they are falsely diagnosed as non-diseased. False positive. They are healthy individuals. They are absolutely healthy. They don't have any disease, but they are identified as diseased as a result of screening test. A screening test which yields false positive is not an ideal one. And true negative, those who don't have the disease. What is the formula of sensitivity? Sensitivity is done for disease, and we are seeing the percentage of true positive among those who are diseased. We know that true positive are diseased and false negative are diseased. So formula will be A over A plus C into 100. 100 because we want to see the percentage. We will count the percentage. This That's how we can calculate the sensitivity. So remember, you will calculate the sensitivity from disease from A and C. Formula will be A divided by A plus C multiplied by 100 because we want to see the percentage. If sensitivity is higher, screening test has more disease ones. If it is lower, it yields non-disease ones. What is specificity? It is the ability of test to correctly identify those who don't have the disease. These are non-disease. Who are non-disease, false positive and true negative. Now we want to see the percentage of screening test which yields true negative. So we will divide D of B plus D and multiply it by 100. Why D is taken? Because true is always taken as numerator. D should be numerator because D are true negative. B are false positive. False positive also means those who are non-disease. So this is the formula for specificity. If specificity is higher, this screening test have non-disease people. Our number of non-disease are greater in this screening test. Let's take an example. A screening test was conducted. EEG, these are the EEG results for brain tumor, presence of brain tumor, absence of brain tumor. Test was positive for these individuals and test was negative for these individuals. When we conducted another test, 36 people whose test was positive was identified as diseased. Their test was positive, but they are not diseased. Four people with negative screening tests were diagnosed as diseased, and 306,000 were non-diseased. This means that test was positive for these individuals, negative for these individuals. But when we did a diagnostic test or when we did further investigation, only 36 were diseased, and four negative results were also diseased, or four individuals whose test was negative, they were diseased. So total diseased people are 40 and non-diseased people 360,000. Sensitivity of this test is 90%, specificity is 85%. So this is a good test, not 100% ideal, but sensitivity is greater and specificity is greater. We can say that this test is 90% sensitive, it is yielding 90% true positives. And this test is 85% specific and it is showing 85% true negatives. These are true negatives. So this is the example. So EEG can be a test for brain tumor. Then we'll calculate the predictive accuracy. There are two types of predictive accuracy: positive predictive value and negative predictive value. What positive predictive value indicate? It indicates the number of true positives in those whose test is positive. So A and B are positive, but A are true positive. So we divide A with A plus B and multiply it with 100. This is formula positive predictive value. Positive predictive accuracy, percentage of true positives in total positive individuals. And what is negative predictive value? Percentage of true negatives among those who are negative. So formula of negative predictive value is D over C plus D into 100. This is the formula for negative predictive value and this is the formula for positive predictive value. A test whose positive predictive value is greater shows that test has greater number of positive results. A test whose negative predictive value is greater shows that test has greater negative results. A test have tendency to produce negative results. This is the practical example that screening test was positive for 60 individuals and it was negative for 9,940 individuals. You can label them as A, B, C, and D. 60 were positive and 9,940 were negative. But after conducting another test, only 40 were diseased, 20 were non-diseased. We can say that 20 were false positive. 100 individuals whose test was initially negative were diagnosed as diseased. 9,840 were not diseased. When we calculate the sensitivity, it is lesser. It is 28.57%. Because out of 40, out of 60, only 40 were diseased. So this test is not sensitive, but this is specific. Out of 9,860, 9,840 were true negative. So this test is specific but not sensitive. Positive predictive value is 66%. This test yields less positive results, but it yields greater negative results. So we can say that this test yields non-disease people. This test yields negative results. This test doesn't yield positive results, or its sensitivity and positive predictive value is lower. Positive predictive value can have effects on our results. What? Prevalence increases. If positive predictive value increases, prevalence in the study increases. Why? When positive predictive value increases, number of disease person increases. If number of disease person increases, prevalence increases. It increases and negative value decreases. So they are inversely proportional to each other. So we can say that our university can ask an MCQ that prevalence and positive predictive value are directly proportional, but prevalence and negative predictive value are indirectly proportional. Burden is increasing, number of positive cases is increasing. When prevalence decrease, if number of positive cases is less, prevalence is decreasing. Number of positive predictive value decreases, prevalence decreases. So you have to remember that positive predictive value and prevalence, they are directly proportional. Positive predictive prevalence and negative predictive value, they are indirectly proportional. When sensitivity increases, positive predictive value increases. When specificity increases, positive predictive value increases. When sensitivity increases, negative predictive value increases. Why? Because sensitivity is also showing diseased. Sensitivity is showing those who are diseased. When it is increasing, automatically number of positive ones is increasing. And sensitivity increase negative predictive value, it increases. Specificity and positive predictive value are directly proportional. And sensitivity and negative predictive value are directly proportional. Specificity means those who are non-diseased, and sensitivity means those who are diseased. What is the relationship between sensitivity and specificity? Indirect relation. If it is increasing, this is decreasing. And what will be effect on false positive? They are increasing. Why? Number of disease ones are increasing. So there are greater chances of false positive. What is the relationship between if specificity increases, sensitivity decreases, and false negative increases? So we can say that sensitivity has direct relationship with false positive, and specific and indirect relationship with specificity. And specificity has a direct relationship with false negative and indirect relationship with sensitivity. So sensitivity and specificity are inversely proportional, but sensitivity is directly proportional to false positive because they are diseased. False positive is positive, and specificity is directly proportional with false negative, but it has indirect relationship with sensitivity. This is the relation. These are the true negative. These are the true positive. False negative and false positive. These are the true curves. This is the criteria. We set a cutoff value. If we decrease the cutoff value, a number of disease increases. If we reduce cutoff value, number of disease increases. If we increase cutoff value, number of disease will decrease. Like in case of diabetes, if we decrease the cutoff value to 180, number of diabetic people will increase. But if we increase the cutoff value to 240, number of diabetic people will automatically decrease. So it depends on cutoff value. We have to set certain cutoff value. Like for hemoglobin, usual cutoff value is 12. But for developing world, we take it as 10. What is the risk of screening? Screening tests can yield false negative, false positive. If it is used yielding true positive, that's fine. Number of disease. For false positive, a person who is not suffering from cancer, but a screening test is showing that he has cancer, he can have cancer. He will suffer from anxiety, he will suffer from fear, and there will be expenses. He will suffer from tension. He will take tension that I am dying, I will die after a certain period of time. This is the greatest disadvantage of false positive. But while we will do diagnostic homework, person will be fine. But till then, he will suffer from anxiety. To generate false negative results is the greater problem. What it will do, it will delay our diagnosis. We will say that person is fine after screening test. It will delay our diagnosis. When diagnosis is delayed, intervention is delayed. When intervention is delayed, it can lead to complications. So there must be some solution. Only solution is rescreening. After few years, after 1 year or 2 year or 3 year, we'll screen the same population. False positive will automatically go to hospital and they will be diagnosed as non-diseased. But where false negative should go, they can't go to the hospital. So we will do rescreening. Plus, you have to remember these things that prevalence increases, positive predictive value increases, specificity increases, positive predictive value increases, sensitivity increases, negative predictive value increases. These can be MCQ questions. Now, we will summarize the session. What we have discussed, we have discussed criteria for disease and test. Criteria for disease is called Wilson criteria. Then criteria of test. What is criteria of disease? It should be a common public health problem. We should know the natural history. Our natural history should be known. Disease must have a latent period, a recognizable latent period. We can recognize, like in case of influenza, disease developed within 72 hours. So there is no need to screen it. But in case of hypertension, latent period is greater, so we need to screen it. There must be some diagnostic test. We should have certain diagnostic tests like for hypertension, for diabetes, for cancer. Then there must be some treatment. We are diagnosing cervical cancer in female. Treatment should be available. We must have chemotherapy, we must have radiotherapy, surgery options should be available, and benefits should be greater. This was the Wilson criteria. The criteria of test should be repeatable, test should be reliable, test should be acceptable, it should not be painful, it should be cost effective, and it should be valid. Most important criteria, it should be valid. What validity means that it should yield true positive results, it should yield true negative results. We see sensitivity, we see specificity, we see predictive accuracy, positive predictive value and negative predictive value. Then we discuss that what are the various problems of screening. It can yield false negative and true false positive results. You know that the results can be positive and negative. Positive results, either they are true positive or they are false positive, and negative results, either they are false negative and true negative. False positive are non-diseased. They will suffer from anxiety. False positive are non-diseased. False negative are diseased. Intervention is delayed, diagnosis is delayed, and they can lead to complications of. So screening test should be done in the community. It is done to provide benefit to the community. And we also studied that sensitivity and specificity are inversely proportional to each other. Sensitivity increases, specificity decreases. We have discussed the example of EEG. So we have also discussed the problem of borderline or cutoff value. We discussed that if we increase cutoff value, number of disease person reduces or decreases. But if we increase cutoff value, number of disease person reduces. But if we decrease, number of disease person will increase. Like in case of high diabetes, if we say that cutoff value is 180, number of diabetics will increase. But if we increase the cutoff value, number of diabetics will decrease. So we have to manage it according to certain cutoff value. And we also discussed that specificity is directly proportional to positive predictive value. Sensitivity is directly proportional to negative predictive value. So these are various values what we are trying to find, and what are various formulas. Formula of sensitivity. And sensitivity indicates that those who are diseased, A and C are diseased. Why? True positive and false negative, they are diseased ones. We want to see the percentage of true positive among the diseased ones. A test which have greater sensitivity must have greater number of true positives. And for specificity, we want to see the percentage of true negative among those who are non-diseased. False positive are also non-diseased. If the percentage of true negative is greater, test is specific. Ideal test should be sensitive and should be specific. And then we have discussed the predictive accuracy. There is positive predictive value and there is negative predictive value. Positive predictive value, we are seeing the percentage of true positive among those who are positive. And for negative predictive value, we are seeing the percentage of true negative among those who are negative. We test our screening. Certain tests can be diagnostic as and screening as well, like pap smear is a screening test and it's a diagnostic test. We select a population, high risk population, high risk female of low socioeconomic status, female those who have multiple sexual partners, female whose hygiene is poor, female of middle age, female who are using OCPs. We must know the risk factor of the disease. That's why I said that we must know the natural history. We must know the risk factors of the disease. We target them and we'll do pap smear. This test is diagnostic and screening. And for diabetes, glucose tolerance test or GTT is a screening test and it's a diagnostic test. So certain tests are screening and diagnostic. Why screening is beneficial? Screening is done for early diagnosis. It's an intervention or secondary prevention. We want to diagnose the disease at earlier stages. Why we want to diagnose the disease at earlier stages? Because we want to treat the disease. We want to limit the complications. We want to protect our community. We want to reduce the burden of disease. We want to reduce the mortality cause certain diseases like hypertension. If someone develops complications, he or she may suffer from cardiac disease. He or she may suffer from stroke. Stroke is a complication of hypertension, and stroke is a disability. It can cause disability. We want to reduce the disability. We want a healthy nation. We want healthy people. That's why we do screening. But screening programs should be cost effective. They should be used for benefit of our community. Like nowadays, we are running screening programs for blindness. In Pakistan, we are running a program for blindness. We are doing screening program for coronavirus. We are screening coronavirus because we want to protect our community, and we have successfully reduced the mortality. We have successfully reduced the morbidity due to a successful program, because in the end we will evaluate our screening programs. Evaluation is important. Why evaluation? Whether our programs, our interventions are successful or not. That's all.